Okay, now today we are again discussing one more important PYTs of surgery, that is Boerhaave syndrome, and we'll discuss about its differentials too. Okay, so what is this Boerhaave syndrome? This is very important topic. So it means that there is spontaneous esophageal perforation. So there is perforation here, and the cause behind this is forceful vomiting against closed glotis. So it is a kind of a barotrauma that we have to remember, and where it is. It is usually seen on the left side. So I'll tell you the ways how can we remember this. So you remember it like, okay, this left ka will remember how we remember it is on left side, and it is barotrauma. This we will remember, and usually present on the lower one third of esophagus. This we have to remember. Now buzzword here will be this Mackler's triad and Hammond's crunch. So how to remember that there is a Mackler's triad? So one thing we have to remember, that there is perforation. There is perforation. So it is a B for Borha, B for there is bore. There is big problem. Okay, so big problem. For that big problem we have Mackler's triad. Okay, so bore say we can remember it also like burst. So there is burst in the esophagus, and it's a big problem. For this big problem we have this Mackler's triad. So for this triad, like it's a problem, big problem. So now the patient is in a critical situation. The mnemonic is very critical situation. Okay, so we have to remember it like what the components of the Mackler's triad we can remember with this mnemonic. Very critical situation. So very is vomiting, critical is chest pain, and situation is surgical emphysema. And one more thing here we see is Hammond's crunch. Hammond's crunch is seen. What is it? It is a pneumomediastinum. So pneumo, the air will be there in the mediastinum, and when we press it, there will be crunching sound. And usually in the question there will be given the history of an alcoholic patient. Now when we see the x-ray, when we'll investigate the patient, when we'll advise him x-ray, we'll see this very classical signs in this Boerhaave syndrome. So all the classical things we have, because it's a big problem, burst is happening here. So like important x-rays are also with this condition. So first is this Neschlerio V sign, Neschlerio V sign. So this is Neschlerio V sign, and the next is this continuous diaphragm. So this is how it is, like you can see continuous diaphragm. We'll see it again now. Okay, just wait. So continuous diaphragm, and this is spinnaker and sail sign. This is how it is, spinnaker and sail sign. Okay, and one more thing is pneumomediastinum. There is air in the mediastinum. Now we have to remember, then if they are like investigation of choice, we have to remember is CECT. For most of the abdominal cases, investigation of choice is CECT. This we have to remember. And the safest contrast is iohexol. And for varium leak, actually there is this perforation. So this is not, varium is not varium can be harmful. Like if it goes in the mediastinum, it can lead to mediastinitis. So we are not preferring it. We are using iohexol, which is safe. But like if they are asking most accurate for leak, if they are typically mentioning this line, then we can answer varium swallow, but we are not using it. So treatment ke liye we have to remember in Boerhaave's, if patient is stable, okay, we can manage him conservatively. If patient is unstable, and if patient is in sepsis, we'll go with surgery. So surgery mein what we are doing the thoracotomy. Okay, and then we are doing the repair of the perforation. We can do it with clips, stents, and we can also use T-tube. Okay, this is all about Boerhaave syndrome, and these all are the important X-ray images with this. Now, what are the key differentials? Okay, that can be given in the like other options which we have to rule out. So first is Mallory-Weiss-Tier. So the mnemonic here will be, okay, just wait. Mallory may we have to remember M, minor, and just mucosa. Okay, So the cause here will be forceful retching, vomiting again, but pathology is different. Here we have to remember the mucosa and submucosal tear. It's a tear, it's not a perforation at GE junction. This is also very important. At GE junction, that was in the lower one third of the esophagus, and that also in the left side. Okay, that was also in the left side. They can also ask this left posterolateral. So we can remember it like in a way, because this is a big problem, burst, critical situation. So anytime patient can lift this word. Okay, so this way we can remember that it is present on the left side. So how do it present this malaried feast here? This we have to remember. This typically finding is this clinical is UGI bleed, upper GI bleed. Hematemesis presentation is there after retching. And one thing we have to remember, there will be like for this malary V's, this is just a tear, so there will be no mediastinum, pneumomediastinum, no emphysema, no Hammond's crunch will be there, and usually it is self-limiting. And if there is like lots of bleeding, if like bleeding hemostasis is not maintained, then we can go with endoscopic hemostasis if needed. Now one more differential we can consider is acute MI with rupture. So here the pathology will be MI with LV free wall rupture. Now how will be the presentation? There will be retrosternal chest pain and patient will be in shock and ECG changes. So typical history will be retrosternal chest pain, hemodynamic collapse hoga, and there will be this pericardial tamponade not associated. So nothing like vomiting wala specifically given. There this retching wala history is given, but here it will be pericardial tamponade and hemodynamic collapse. And then spontaneous pneumothorax or rupture of the bullae. Okay, what is happening now? The air leak from the lung into the pleural cavity. So there will be pleuritic chest pain, sudden pleuritic chest pain, dyspnea, hyperresonant. Now there is air in the pleural cavity, so it will be pneumothorax. It will be hyperresonant chest, absent breath sounds. There will be no history of vomiting, and when you do the X-ray, you will see the collapsed lung. So there, this is the comparison table. This Boerhaave and Mallory Weiss. This we know. This we have done. Full thickness. Okay, burst. This trigger we know. Like here is this closed glottis. This B say we have remember barotrauma. Okay, how does it presentation? It present UGI, Mallory Weiss, and there it is this chest pain and emphysema. And Mackler's triad we have read, clinical signs, Hammond's crunch, pneumomediastinum, there is this hematemesis, and this Neslerio Weiss, Spinnaker, continuous diaphragm, all are with Boerhaave, and here on Mallory Weiss, just on endoscopy will see the tear. Okay, now conservative management and surgery is like if patient is stable, we can do conservative management. If patient is unstable, we can go with surgery, and Mallory Weiss में mostly conservative management is preferred. MI में we know that this LV free wall rupture and chest pain show presentation, ECG changes will be seen, tamponade will be seen, no such vomiting history specific is given. We go for imaging, we can do is ECG, echo, and it is an emergency surgery. Okay, pneumothorax may we have to remember like there's the spontaneous can happen due to trauma can happen, and there will be sudden presentation will be like sudden dyspnea like complaint, and when you do examination clinical signs with the absent breath sounds will be absent and hyperresonance can be seen, and when you do imaging you will see collapsed lung on the X-ray, and emergency may we have to remember like how do we manage it? Treatment is that we just insert the chest tube. Okay. One more condition can be like perforation of the peptic ulcer. This we also know that this can also happen. History of ulcers in the patient and usually in the stomach and the duodenum, and so we have to remember like presentation will be like acute abdomen, and here the typical this line is must that will be given, that air under the diaphragm. Whenever there is this perforated ulcer, there will be free air under the diaphragm, and when you do the X-ray, air under the diaphragm, and immediate laparotomy is done. So for this we have to you have to remember collapsed lung. This will give you enough clue, and this ECG changes and tamponade. So other thing we can remember like okay, this we have done. Okay, perforated may we have to remember na, this is present, ulcers are present in this stomach and duodenum. So there will be free air under the diaphragm and not associated. There will be no pneumomediastinum. Okay. So other mimickers can be like pulmonary embolism. Here there will be pleuritic pain. There can be dyspnea and not vomiting. And there is one more condition like aortic dissection. So here this typical line is written that there will be tearing pain radiating to the back. Patient will typically say that pain is radiating to the back. Pulses will be unequal and widened mediastinum. This is very important. All three clues for aortic dissection. Okay, so rapid recall Boerhaave may we know that vomiting is with closed glotis and there is full thickness rupture and pneumomediastinum. Mallory V is minor mucosa hematemesis presentation. MI may it is post MI chest pain tamponade presentation. Pneumothorax may suddenly patient will present with dyspnea, and when you percuss the patient like when you auscultate there will be absent breath sounds, and when you do the percussion there will be hyper resonance, and in perforated peptic ulcer patient's presentation will be like acute abdomen, and when you get an x-ray done, imaging done, you will see air under the diaphragm. So this way we have learned about all the differentials along with this topic of Boerhaave syndrome. Okay, so this is I think very important topic which is important from INI side, NEET PG and FMG exam. Okay, thank you.